Welcome back to Menopause University. I always greet you by assuming you aren't new to my channel, and that's because this channel is really a classroom that gives you a real education. And you can no more get a real education by starting with any video other than video number 1 and learning everything in order than you could learn to read without first learning the alphabet. So don't expect me to greet you as if you're new to this education. You already know that my mission is to empower you with everything you need to know in order to manage any aspect of your menopausal life. And my goal is to ensure that your menopausal life is very long and very pleasant. So I teach you how to avoid all the things that can interfere with a long, pleasant menopausal life. And epithelial ovarian cancer is one of the most critical things to avoid. As you've seen with all the previous disease units, I present all your management options for preventing each disease we study. And this is the first video on the management options for preventing epithelial ovarian cancer. This is video number 442. This particular video will address prevention of epithelial ovarian cancer in high-risk women. Subsequent videos will address each category of prevention individually, and then I'll give you a video that compares them all. Now, this video is going to give you so much more than you get in my book, whether you have the first or the second edition. You know, the very best way to get this education is to watch the videos in order and also refer to the book. That way you'll understand everything you read in my book at an even deeper level. Now, I've made mention in previous videos that the topics for this unit are somewhat out of order. And this is yet another instance in which I am delivering the information in an unusual order. Typically, when presenting management options for preventing a disease, I start with the diet and lifestyle options that serve all women, regardless of their degree of risk for the disease. And then I typically work my way up to the more medical and more invasive options suitable for high-risk women. But I'm going to reverse the order this time. This time I'm going to start with the means of prevention in women at highest risk of epithelial ovarian cancer and work my way down to the means of prevention for women at lowest risk for epithelial ovarian cancer. And there are a couple of reasons for my decision to reverse the order. The first and most important reason is that women at highest risk for epithelial ovarian cancer are the ones who need to prioritize prevention the most. The second reason is that it's very difficult for any woman other than those with a genetic mutation to know that she's at high risk for epithelial ovarian cancer. The third reason is that unlike the other diseases that have options for prevention in many different categories, epithelial ovarian cancer only has options in just a few categories. I've already schooled you in the risk factors for epithelial ovarian cancer. The list of risk factors for any disease always determines your options for preventing it. But with epithelial ovarian cancer, despite the long list of risk factors, the options for preventing it are few. Take a look at our big chart of risk factors for epithelial ovarian cancer. You've seen this dozens of times now. The only categories for which there are any management options for prevention are hereditary risk factors, hormonal risk factors, lifestyle risk factors, and psychological risk factors. And for those categories, the only preventive options available consist of surgery, hormonal medications, lifestyle, and exercise. Today I'll present the preventive measures you can take to lower your risk based on hereditary risk factors, which are in green, and they constitute only 20% of epithelial ovarian cancers. These are the ones that pertain to the women at highest risk. These same measures can also serve to lower your increased risk due to your own personal history, which is in pink. You can't change anything about your family history in purple or your personal profile in yellow. And the only other category for which this tutorial can serve to lower your risk is inflammatory risk factors in red. So, for our focus today, we will be looking at how you can prevent epithelial ovarian cancer if you are at high risk for the disease. These measures are very, very effective, but only a minority of women who get epithelial ovarian cancer know that they are high risk for it. So it turns out that the most effective means of preventing epithelial ovarian cancer serve only a small minority of women, 20% at most. This is the prop I created for video number 413, which was the very first video in this unit. Have you noticed that I plant seeds of knowledge early on and bring them to fruition later on? This is yet another reason why watching my videos in order is so important. This train track demonstration shows you the different kinds of epithelial ovarian cancer that develop from cells resembling the different parts of your reproductive tract. Here it is on the chart we created way back in that video. Cells resembling your ovaries and fallopian tubes generate serous epithelial ovarian cancer. Cells resembling your uterus generate endometrioid and clear cell epithelial ovarian cancers. Cells resembling your cervix generate mucinous epithelial ovarian cancer. So every part of your reproductive tract is culpable and capable of possibly generating at least one kind of epithelial ovarian cancer. Well, the means of preventing all these epithelial ovarian cancers in high-risk women involves surgical removal of the organs from which these cancers can originate. The question is, just which organs should you remove for purposes of prevention? Well, that's for you to decide. What I'll do is delineate the various options for surgical procedures and give you the pros and cons of each. At first, I'll only give you the pros and cons with regard to cancer prevention. And then I'll put them into perspective with regard to the non-cancer matters like menopause itself. Underlying all these surgical procedures is the confirmed, absolute, indisputable fact that the only intervention that is definitely effective in decreasing the risk and incidence of epithelial ovarian cancer in women who have a hereditary predisposition for it is bilateral salpingo-oophorectomy. Way back in video number 8, I taught you the terms for surgical procedures involving your reproductive tract. Bilateral salpingo-oophorectomy means removal of both fallopian tubes and both ovaries. The fallopian tubes are the green beans and the ovaries are the walnuts. The acronym for bilateral salpingo-oophorectomy is BSO. Bilateral means both sides. Salpingectomy means removal of a fallopian tube. Oophorectomy means removal of an ovary. So the recommendation for all women who have a known hereditary increased risk for epithelial ovarian cancer is to have a BSO, which is surgical removal of both fallopian tubes and both ovaries after completion of childbearing. This recommendation is in all guidelines for ovarian cancer prevention, every single one of them. And that's because the only guaranteed way of definitely reducing your risk of epithelial ovarian cancer is bilateral salpingo-oophorectomy. It's tried and true. But there are many different modifications that you can make to this. Some are a matter of practicality. Some are a matter of logic. Some are a matter of illogic. I'll present them all. You can decide for yourself what makes the most sense to you. And I'll present them in order of extent, with the most extensive surgical procedure first. All told, we will discuss all the following risk-reducing surgical procedures: total hysterectomy, bilateral salpingo-oophorectomy; partial hysterectomy, bilateral salpingo-oophorectomy; bilateral salpingo-oophorectomy; bilateral salpingectomy; and bilateral tubal ligation. Now, don't worry about all these long words for surgical procedures. I'll demonstrate each one so that you have a visual understanding of what each entails. Now, all are labeled as risk-reducing surgical procedures. And this is because the very reason for the surgery is to reduce your risk for epithelial ovarian cancer. And the acronym for risk reducing is RR. RR, like railroad. So you just add RR at the beginning of each acronym for the surgical procedure. But I think the more proper label is life-saving. Just add life-saving before each of these surgical procedures, and then you start getting their real purpose. Okay, let's go through them one by one. The most extensive of the risk-reducing surgical procedures is a risk-reducing total hysterectomy, bilateral salpingo-oophorectomy. And the acronym would be RRTHBSO. Now, going back to what you learned in video number 8, a total hysterectomy is removal of your uterus and your cervix. And bilateral salpingo-oophorectomy is removal of both fallopian tubes and both ovaries. So this procedure removes all your reproductive organs. And if you've completed your childbearing, you don't need them anymore. So you aren't removing any organ that still serves any reproductive purpose, and we'll address the effect on menopause separately. So the balancing act is between keeping organs that serve no reproductive purpose versus removing them because they are at high risk of becoming cancerous with a very deadly cancer. And how much cancer risk reduction do you gain by removing your uterus, cervix, fallopian tubes, and your ovaries? What's the degree of benefit? Well, removal of your uterus reduces your risk of endometrial cancer by 100% and other uterine cancers by 100%. It reduces your risk of endometrioid epithelial ovarian cancer by 90% and clear cell epithelial ovarian cancer by 90%. Removal of your cervix reduces your risk of cervical cancer by 100%. And mucinous epithelial ovarian cancer by 90%. Removal of both fallopian tubes reduces your risk of serous epithelial ovarian cancer by up to 90%. The up to 90% is critical because both your fallopian tubes and your ovaries can be the source of serous epithelial ovarian cancer. The only way you can be sure to get the full 90% reduction in risk is to remove both fallopian tubes and both ovaries. Removal of only your fallopian tubes or only your ovaries may or may not significantly decrease the degree of benefit depending on where the cancer originates. Removal of both ovaries reduces your risk of serous epithelial ovarian cancer by up to 90% and breast cancer by 50%. That's right, removing both ovaries also reduces your risk of breast cancer, even though your breasts are not part of your reproductive tract. So removing all these organs reduces your risk for a whole lot of cancers. If we put all of this on an isolated chart, for just the cancer risk-reducing benefits of total hysterectomy, bilateral salpingo-oophorectomy, we get this. On this chart, I'm using the acronym EOC for Epithelial Ovarian Cancer. So you can see that you get a whole lot of cancer risk-reducing or life-saving benefits from a total hysterectomy, bilateral salpingo-oophorectomy. You essentially completely erase your risk of all cervical cancers by 100%, all uterine cancers by 100%, all types of epithelial ovarian cancer by 90%, and breast cancer by 50%. Okay, the next, slightly less extensive of the risk-reducing surgical procedures is a risk-reducing partial hysterectomy bilateral salpingo-oophorectomy. The acronym for this is RRPHBSO. Going back to what you learned in video number 8, partial hysterectomy is removal of your uterus only without removing your cervix. And it includes removal of both fallopian tubes and both ovaries. So this procedure removes all your reproductive organs except your cervix. And if you've completed your childbearing, you don't need them anymore. You know, your cervix is nothing but a door to your uterus that lets sperm in and periods and babies out. So you don't need it either. Notice that your cervix is a reproductive organ. It has absolutely nothing to do with your sex life. With partial hysterectomy, bilateral salpingo-oophorectomy, you are not removing any organ that still serves any purpose. And again, we'll address the effect on menopause separately. So the balancing act is between keeping organs that serve no reproductive purpose or removing them because they are at high risk of becoming cancerous. And how much benefit do you gain by removing your uterus, fallopian tubes, and ovaries? Well, removal of your uterus reduces your risk of endometrial cancer by 100%, other uterine cancers by 100%, endometrioid epithelial ovarian cancer by 90%, and clear cell epithelial ovarian cancer by 90%. Removal of both fallopian tubes reduces your risk of serous epithelial ovarian cancer by up to 90%. But again, the only way you can be sure to get the full 90% reduction in risk is to remove both fallopian tubes and both ovaries. Removal of only your fallopian tubes or only your ovaries may or may not significantly decrease the degree of benefit, depending on where the cancer originates. And removal of both ovaries reduces your risk of serous epithelial ovarian cancer by up to 90% and breast cancer by 50%. Retaining your cervix maintains your risk of cervical cancer at 100% and mucinous epithelial ovarian cancer at 100%. So removing all of these organs reduces your risk for a whole lot of cancers, but not as many as if you'd removed your cervix also. If we put this on an isolated chart for just the cancer risk-reducing benefits of partial hysterectomy, bilateral salpingo-oophorectomy, we get this. Now you see that you still get a whole lot of cancer risk-reducing benefits from a partial hysterectomy, bilateral salpingo-oophorectomy. You essentially completely erase your risk of all uterine cancers by 100%, all types of epithelial ovarian cancer by 90%, except mucinous epithelial ovarian cancer, and breast cancer by 50%. And you retain your risk for all types of cervical cancer in general. The next less extensive risk-reducing surgical procedure is a risk-reducing bilateral salpingo-oophorectomy. Its acronym is RRBSO. This is the procedure recommended by all the guidelines for prevention of ovarian cancer. Bilateral salpingo-oophorectomy, or BSO, is removal of just both fallopian tubes and both ovaries. And how much benefit do you gain by removing both of your fallopian tubes and both of your ovaries? Removal of both fallopian tubes reduces your risk of serous epithelial ovarian cancer by up to 90%. Removal of both ovaries reduces your risk of serous epithelial ovarian cancer by up to 90%. And it reduces your risk of breast cancer by 50%. By removing both fallopian tubes and both ovaries, you can be sure to get the full 90% reduction in risk. This is precisely why bilateral salpingo-oophorectomy is the recommended risk-reducing procedure for all women having a genetic mutation for epithelial ovarian cancer. Retaining your uterus maintains your risk of endometrial cancer at 100%, other uterine cancers at 100%, endometrioid epithelial ovarian cancer at 66%, and clear cell epithelial ovarian cancer at 66%. And retaining your cervix maintains your risk of cervical cancer at 100% and mucinous epithelial ovarian cancer at 100%. So removing these two organs reduces your risk for cancers in two locations: some ovarian cancers and breast cancer. If we put this on an isolated chart for just cancer risk-reducing benefits of bilateral salpingo-oophorectomy, we get this. So with just bilateral salpingo-oophorectomy, you reduce your risk of serous epithelial ovarian cancer by 90%, endometrioid epithelial ovarian cancer by 34%, clear cell epithelial ovarian cancer by 34%, and breast cancer by 50%. So the risk-reducing benefits aren't nearly as great as they are when you remove your uterus and cervix in addition to both ovaries and both fallopian tubes. The next to least extensive risk-reducing surgical procedure is a risk-reducing bilateral salpingectomy, or RRBS. This is the procedure that some people are promoting instead of the risk-reducing BSO. So, BSO versus BS. Bilateral salpingectomy is removal of just both fallopian tubes. And how much benefit do you gain by just removing your fallopian tubes? Removal of both fallopian tubes only reduces your risk of serous epithelial ovarian cancer by up to 90%. But remember, the only way you can be sure to get the full 90% reduction in risk is to remove both fallopian tubes and both ovaries. Removal of only your fallopian tubes or only your ovaries may or may not significantly decrease the degree of benefit depending on where the cancer originates. And the people who promote this BS in place of the BSO claim that it serves the same purpose as the risk-reducing BSO. It doesn't. And notice that you do not reduce your risk for breast cancer at all with this BS. But most women who are at high risk for epithelial ovarian cancer are also at high risk for breast cancer. So you don't get nearly as many risk-reducing benefits with BS as you do with BSO. So, removing just your fallopian tubes reduces your risk for only serous epithelial ovarian cancer by up to 90%. You may possibly reduce your risk for endometrioid epithelial ovarian cancer by up to 34%. And you may possibly reduce your risk for clear cell epithelial ovarian cancer by up to 34%. But by retaining your ovaries, that is not a certainty. Retaining your ovaries maintains your risk of serous epithelial ovarian cancer originating in your ovaries at 100% and breast cancer at 100%. So removal of only your fallopian tubes and not your ovaries is actually not allowed if you are actually at high risk of serous epithelial ovarian cancer due to a genetic mutation. Well then, why would anyone promote it at all for any woman? Retaining your uterus maintains your risk of endometrial cancer at 100% and all other uterine cancers at 100%. It maintains your risk of endometrioid epithelial ovarian cancer at 66% and clear cell epithelial ovarian cancer at 66%. And retaining your cervix maintains your risk of cervical cancer at 100% and mucinous epithelial ovarian cancer at 100%. If we put all this on an isolated chart for just the cancer risk-reducing benefits of bilateral salpingectomy, we get this. So the difference between removing only your fallopian tubes rather than your ovaries and your fallopian tubes is that you reduce your risk of some epithelial ovarian cancers only. You do so to a lesser degree, and you completely forfeit reduction of breast, uterine, and cervical cancers. The last, least extensive risk-reducing surgical procedure is a bilateral tubal ligation, or RRBTL. Now this one is sort of made up. It's not an official risk-reducing surgery for serous epithelial ovarian cancer at all. The only epithelial ovarian cancers for which it can possibly reduce risk are the two that are associated with the retrograde travel of cancer cells from the uterus through the fallopian tubes and onto your ovaries. Those two are endometrioid epithelial ovarian cancer and clear cell epithelial ovarian cancer. It completely ignores the serous epithelial ovarian cancer that is the most common and most deadly ovarian cancer. It's on our list only because some medical literature cites lower risk of these two types of epithelial ovarian cancer in women who have had bilateral tubal ligations. Bilateral tubal ligation means severing or occluding both fallopian tubes. You just literally put like a kink in it. Some BTLs involve removing a small segment of your fallopian tubes. Others involve merely occluding them. Regardless of how the procedure is performed, it serves to prevent passage of anything through your fallopian tubes. That's the only way it can reduce your risk. And how much benefit do you gain by ligating your fallopian tubes? Ligating both fallopian tubes reduces your risk of endometrioid and clear cell epithelial ovarian cancers by up to 34%. And the people who promote BTL in place of BSO claim that it serves the same purpose as the risk-reducing BSO, but that is definitely not true. Once again, notice that you do not reduce your risk for uterine or cervical or breast cancers at all with BTL. So ligating your fallopian tubes reduces your risk for only endometrioid and clear cell epithelial ovarian cancers, and only a little bit. You do not reduce your risk for any of the other epithelial ovarian cancers or any of the non-epithelial ovarian cancers. And you do not reduce your risk for the most deadly one of all. Retaining your fallopian tubes, even though ligated, does not reduce your risk for serous epithelial ovarian cancer even a tiny bit. Retaining your uterus maintains your risk of endometrial cancer at 100%, other uterine cancers at 100%, endometrioid epithelial ovarian cancer at least 66%, and clear cell epithelial ovarian cancer at least 66%. And retaining your cervix maintains your risk of cervical cancer at 100% and mucinous epithelial ovarian cancer at 100%. Retaining your ligated fallopian tubes maintains your risk of serous epithelial ovarian cancer up to 100%. And retaining your ovaries maintains your risk of serous epithelial ovarian cancer originating in your ovaries at 100%, and it maintains your risk of breast cancer at 100%. If we put all this on an isolated chart for just the cancer risk-reducing benefits of bilateral tubal ligation, we get this. So a bilateral tubal ligation only reduces your risk for the two kinds of epithelial ovarian cancer that travel up your fallopian tubes: endometrioid epithelial ovarian cancer and clear cell epithelial ovarian cancer. And it does so by up to only 34% compared to the 100% with complete removal of your fallopian tubes. Both bilateral salpingectomy and bilateral tubal ligation are risk-reducing proposals that have cropped up only due to the current fear of HRT on the parts of both women and medical professionals. This is what I discussed in the last video. It is only since the WHI study of 2002 that scared women about replacing estrogen that anyone has looked for a reason to retain ovaries. And even though epithelial ovarian cancer is just about the worst cancer around, that fear of hormone replacement has overshadowed the fear of this horrible cancer. Isn't that shocking? Can you imagine anyone fearing insulin replacement more than pancreatic cancer? Well, that's precisely what this amounts to. People are placing fear of a hormone deficiency above fear of a highly fatal cancer. It's just insane. So there you have it. Everything from removal of all your reproductive organs to mere ligation of your fallopian tubes as risk-reducing procedures for preventing epithelial ovarian cancer. If we make a collective chart of all these procedures together, you can see how much each procedure accomplishes in terms of risk reduction for epithelial ovarian cancers. I know this chart is very busy, but it merely displays exactly what I just presented to you, one procedure at a time. And here's a chart showing the risk reduction achieved by removal of each organ individually. In other words, it shows you the contribution of risk reduction organ by organ rather than surgical procedure by surgical procedure. These charts help you see how much risk-reducing benefit you get out of removing each organ or by having one procedure or another. Both charts are available at menopausetailor.me and via the link in the description box for this video. But wait, we aren't quite done. Now we need to put all this in the context of menopause. Recall that the recommendation for all women who have a known hereditary increased risk for epithelial ovarian cancer is to have a BSO, which is surgical removal of both fallopian tubes and both ovaries after completion of childbearing. Obviously, it says nothing, absolutely nothing, about the consequences of BSO on your menopause. And all mention of menopause is missing for a couple of reasons. One reason is that whether or not removal of both ovaries will cause postmenopause depends on your age at the time of the surgery. If you are premenopausal at the time of ovary removal, you will become postmenopausal as a result of the surgery. And postmenopause that results from surgical removal of your ovaries is sudden. This is in contrast to the gradual menopause that occurs when your ovaries spontaneously go out of business and close down the hormone factory themselves. And depending on your age, removal of your ovaries could result in premature menopause. Premature menopause is postmenopause that occurs at or before the age of 45. So the biggest disadvantage of having a risk-reducing bilateral salpingo-oophorectomy is that it may cause sudden premature postmenopause. And this is a significant thing to consider because the women at highest risk for epithelial ovarian cancer are at high risk mostly because of a genetic mutation for it. And cancers that are caused by a genetic mutation are the cancers that occur at the youngest ages. Postmenopause has its own risks. It consists of the risks associated with the diseases of estrogen deficiency, heart attack, osteoporosis, and Alzheimer's. The earlier in life you become postmenopausal, the higher your risk for these three diseases also. So you have a balancing act. You have to balance your risk of epithelial ovarian cancer and its horribly high mortality rates against the risks of estrogen deficiency. But wait, there are are easily accessible ways of preventing the diseases of estrogen deficiency. All you have to do is take estrogen replacement. The ironic thing is that the very group of women that is at highest risk of epithelial ovarian cancer and should consider BSO is the same group of women that tends to be most afraid of taking estrogen replacement. This is one of those trade-offs. And the reason it's so important to address this is that risk-reducing bilateral salpingo-oophorectomy is the only guaranteed way of reducing your risk for epithelial ovarian cancer. Nothing else comes even close. So what sounds best to you? Having a risk-reducing BSO at a young age to reduce your risk of epithelial ovarian cancer, and taking estrogen replacement to prevent the diseases of estrogen deficiency. Or having a risk-reducing BSO at a young age to reduce your risk of epithelial ovarian cancer, and rejecting estrogen replacement so that you increase your risks of all the diseases of estrogen deficiency. Or 3, rejecting risk-reducing BSO and maintaining your risk of epithelial ovarian cancer, and also rejecting estrogen replacement so that you increase your risks of all the diseases of estrogen deficiency. Of course, I'm not even including all the other risk-reducing surgical procedures here. I'm just presenting the idea of trade-offs for BSO to non-BSO. You can choose a risk-reducing surgical procedure at any age. The younger the age at which you have the surgery, the more you reduce your risk of cancers. The older the age at which you have the surgery, the less you reduce your risk of cancers. Why is this? Well, it's because of what I explained to you in video number 437 on the diagnosis of epithelial ovarian cancer. There is something called occult cancer. Occult epithelial ovarian cancer is when the cancer is already in your ovaries, but you have no idea that it's there. It has not spread outside your ovaries, and it has not caused any symptoms whatsoever. It isn't even visible to the surgeon's naked eye at the time of surgery. It is only when the pathologist examines your ovaries under a microscope that he or she makes the diagnosis of occult epithelial ovarian cancer. So you decrease your risk of sudden premature menopause by having a risk-reducing BSO at an older age, but you increase your risk of occult epithelial ovarian cancer by having a risk-reducing BSO at an older age. Like I always say, everything, absolutely everything, is a matter of trade-offs. What matters the most to you? I've charted these trade-offs for you too. This simple 4-square chart shows you 4 cells. The pink cell shows that the younger you are when you have risk-reducing surgery, the higher the risk of premature menopause. The green cell shows that the younger you are when you have risk-reducing surgery, the lower your risk for cancers. The orange cell shows that the older you are when you have risk-reducing surgery, the lower your risk for premature menopause. And the aqua cell shows that the older you are when you have risk-reducing surgery, the higher your risk for cancers. Trade-offs, trade-offs. Life is all about trade-offs. So that does it for the risk-reducing surgical procedures for women with a high risk of epithelial ovarian cancer. Your summary consists of the last 3 charts, which you can find at menopausetailor.me or via the link in the description box. And added to that, as part of your summary, is this. The recommendation is for all women who have a known hereditary increased risk for epithelial ovarian cancer to have a BSO, bilateral salpingo-oophorectomy, after completion of childbearing. And depending on their age at the time of bilateral salpingo-oophorectomy, the surgery may induce sudden and/or premature menopause. If so, they need to consider estrogen replacement to prevent the diseases of estrogen deficiency. Now, some of you who are not at high risk for epithelial ovarian cancer due to a known genetic mutation may be saying, what about me? Are there risk-reducing surgical options for me? Face it, while hereditary epithelial ovarian cancer is more predictable, it is not more common than non-hereditary epithelial ovarian cancer. Heredity accounts for only 20% of them. All the others are non-hereditary. So women who are not at high risk for epithelial ovarian cancer due to a genetic mutation need risk-reducing options too. So that's what I'll address in the next video entitled Elective versus Opportunistic versus Risk-Reducing Gynecologic Surgeries. I sure do like giving you these tutorials on all things related to menopause. If you benefit from them even 10% as much as I enjoy delivering them, then that's my reward. It is just such a joy to know that I am saving lives left and right here on YouTube. And I can save your life in a way that is tailored specifically to you in a consultation. Please schedule one at menopausetailor.me. I promise it will be the best thing you could possibly do, and I do them all via video conferencing so that you can have one no matter where you live. And please subscribe right here to this channel and to my newsletter. I promise that you'll benefit from that too. Following me on social media is optional. If you want to find me there, go to Facebook, Instagram, Twitter, and TikTok. And I will see you again in a week. Bye!